Next, I would like to call Dr. Shaji, who's our chief instructor, to present about biometry in challenging situation. He's the cornea phaco-refractive surgeon working in Abeta Hospital, Perindavanna.
Okay. Good morning, everyone. We are in an area wherein the litigations against phaco surgeons are increasing. Why? Because the phaco surgery is now considered as a equivalent to refractive surgery. So the patient's expectations are more, and here the main culprit is usually the biometric evaluation. So we have to ensure that our biometric platforms are on a stronger basis all the time. And it's even more challenging when the situations are more difficult to deal with. So the few difficult situations I have kept in mind is when you have a poor corneal or ocular surface, when you have to do a biometry post-refractive surgery, the detail would be given by Dr. Chitra Madam. And when you have a toric IOL calculation, when you have biometry in irregular corneas, when you have to do biometry in post-penetrating keratoplasty, when you have to do biometry in dense cataracts, when you have to do biometry post-retinal surgeries, and of course biometries in high myopes and hypermetropes. So to begin with, when you have to think about, when you're seeing a poor cornea or a bad ocular surface, we always have to keep a history of whether the patient has been using contact lenses. So if the patient is on soft contact lenses, we have to ensure that they have removed the soft contact lenses for the past 3 days. If the patient is having rigid contact lenses, it should be removed for at least 3 weeks. And if it's toric, it has to be removed at least 1 week prior. And if the patient is having meibomian gland dysfunction, bad dry eye or SP case, make sure this is treated first and then biometry is being advised. So the next the detail will be dealt with Dr. Chitra Madam. So here the main things we have to keep in mind is the alterations in the corneal curvature. We know it can result in one diopter with a small error, and the effective lens position calculations is usually wrong, and we usually underestimate the myopic, and myopic patient usually land up post-op retinal surgery biometry, they become hyperopic. So the instrument error is one thing to deal with, because it is the 3 millimeter zone, even the central area is at different curvatures. And the next thing is the relationship of refractive index of 1.337 after altering the corneal curvature or making it flatter is no longer standing. So most of the IOL formulas of calculating at 1.337 again gives us error. So here we have lot of formulas to deal with, and it is mainly the holiday EKR that is gaining important equivalent K reading to get a good K. It is calculating, and the highlight here is we keep or calculate it at 4.5 millimeters, and we take the EKR mean of 65 to get a good K value for the formulas. And the formula error, usually as I said, the effective lens position is wrongly placed to be more anterior, and again the patient would land up in a hyperopic mode. And easy way out would be to take up the ASCRS calculator and get the power out. The next thing is again the toric IOL calculation. So here it is, we know we have a lot of IOL calculators that is available online. One thing to be highlighted here is we have to take care about the posterior curvature of the cornea, and that has to be recorded. Otherwise, we may land up with a wrong biometric value. And if it is calculated to be with the rule is missed, then the patient would land up in over refraction, and if it's against the rule is missed, the patient may land up in an undercorrection. And the next thing we keep in mind is how about the biometry in irregular corneas. So as I said, the relationship of between the anterior curvature and posterior curvature is important. The formulas would work out well. But when that relationship is altered in irregular corneas, then that is no longer standing, and we may land up with a wrong biometric value. So here, by learning the topography for every cataract surgeon is important, and we should not miss a case of keratoconus or a case of pellucid marginal degeneration, a case of post-LASIK ectasia or a decentered ablations. And if you have a very bad irregular cornea, it's always recommended to go about and take 3 readings, make sure we are looking at a irregular area, and then we can, now since the refractive surgery have developed much, we can first smoothen up the cornea by topo-guided customized ablation, and then go about and do a good biometry and get a good result. The next thing is in penetrating keratoplasty, again, in penetrating keratoplasty, we know we usually land up with high cylindrical values in post-keratoplasty cases. And here the idea now is in the toric IOLs give us a maximum of -6. But now if it is more than 14, we actually have the freedom of customizing the intraocular lenses. And the next is in cases of hard cataract, we know the calculations of axial length is usually important. And here the main thing is the errors occur in calculating the axial lengths, and we have to make sure that we are not using the older methods, and we may have to go about and do the latest optical biometers, or also take up the ultrasonic immersion techniques to get a good axial length. And when taking the measurements, we have to make sure that we are checking the standard deviations from the optical biometers and the sound noise ratios also. And we should not take deviations that is more than 0.2 diopters, or a sound noise ratio of less than 2 is not taken up. And the next is in post-retinal surgeries, we have to be sure, we have to make sure that the IOL calculation, while doing the IOL calculation, we have to, in silicon oil as well as in vitrectomized eyes, we have to take care of the axial length, and we can take it as 2/3. And also in there are also techniques of calculating it intra-op. And in high myopes, while doing the biometry, we have to take care of, there are a lot of formulas that is being available, and we usually use the Barrett's-Truquet, we have the Holiday system, and we also have the RBF-Hill to calculate the IOL powers. And in hypermetropes, the Haigis and Hofer-Q gives us good results. And also make sure about the asphericity of the cornea, because in prolate corneas we can land up in myopic. Also take care of the higher order aberrations of the cornea. With that, I thank you all for your patient listening.